Hello, my name is Eric Swei, and on behalf of my co-authors, I would like to thank GIE for accepting our manuscript for publication and for giving us the opportunity to answer questions about our study, which examines the effect of per-oral endoscopic myotomy with a short versus standard length myotomy in patients with sigmoid achalasia. So the first question is, why did we choose to study this? Well, although POEM is established as primary treatment modality for achalasia, as those in our audience who perform POEM know, sigmoid achalasia represents a particularly challenging subtype of achalasia that can be very difficult to treat. This diagram demonstrates several of the pitfalls that may be encountered during POEM for sigmoid achalasia. Patients often have angulated, tortuous esophageal lumen, which can make identifying tissue planes for submucosal dissection difficult. Furthermore, these patients often have changes of chronic stasis, including inflammation and edema, which can lead to inadvertent mucosotomy during the procedure and make closure difficult. For this reason, we believe it's critical to find ways to simplify the procedure, improving accessibility for both patients and providers performing POEM. Shortening the myotomy is one way to reduce the technical demand of POEM. However, the effectiveness of this technique has not previously been studied in patients with sigmoid achalasia, and one concern is that a short myotomy could provide incomplete symptom relief compared to standard length myotomy. It was important to us to figure out if this was the case and to characterize any other differences in procedural or clinical outcomes. So how do we recruit patients? One difficulty encountered in studying this question is that achalasia is a rare disease with a prevalence of about 1 in 10,000 patients, and sigmoid achalasia doubly so, as this represents a severe end-stage form of achalasia. For this reason, we retrospectively evaluated patients from a multicenter cohort that included 12 tertiary care centers across 7 countries. We selected patients with sigmoid achalasia who successfully completed POEM. The presence and severity of sigmoid achalasia was determined based on Japan Esophageal Society criteria, where the angulation and tortuosity of the esophageal lumen determines the presence of sigmoid achalasia, and the severity of that angulation classifies a patient as having either sigmoid or advanced sigmoid achalasia. After these patients were classified as having either sigmoid or advanced sigmoid achalasia, they were further evaluated to see whether they had undergone short or standard length myotomy, using a definition of short as a myotomy length of less than or equal to 4 centimeters. This definition was chosen based on precedent from looking at several other studies. So what are the key takeaways from this study? Well, among 109 patients who had POEM for sigmoid achalasia, 59 of which had short myotomy and 50 of which had standard myotomy, the clinical success at a follow-up time of a median of 3.6 months was not significantly different between groups. Interestingly, when we examined a subgroup of patients who underwent ultra-short myotomy, that is to say, those who had a myotomy of 2 centimeters or less, the clinical efficacy dipped to 85%. Now, this difference was not statistically significant when compared to the standard or the short myotomy group, possibly due to the small sample size of only 27 patients falling into this category. However, it does suggest that there is a threshold at which a myotomy becomes too short and then ineffective. But the important conclusion from this study is that a short myotomy seems to be just as effective as a standard myotomy for the treatment of sigmoid achalasia. One other key takeaway in this study is regarding reflux, which is always a concern when discussing POEM for achalasia. Among patients who underwent reflux testing, we found that 22% of patients had reflux symptoms and 44% of patients had pathologic reflux at follow-up, which is comparable to what we've seen in prior studies. Interestingly, we found that rates of reflux were significantly increased in the standard myotomy group versus the short group. To us, this makes sense as a shorter myotomy may selectively preserve the gastric sling fibers, reducing post-POEM reflux. This effect has been seen several times in other studies. Adding to what is already known in the literature, this is an exciting result as it suggests that perhaps a shorter myotomy may be key to reducing the chance of post-POEM reflux. It should be clear, though, that we refrained from drawing strong conclusions in our study, given the low number of patients that had follow-up reflux testing at approximately 35% of the cohort. So what are the next steps? There are a couple things that come to mind regarding next steps. First, although we know short-term outcomes, We know that POEM failure can occur at up to 5 years out, and it will be important to follow this cohort out to see how failure rates for each treatment arm differ over time. Next, while this study shows promising results, it is limited by its retrospective nature. A multicenter prospective trial of short myotomy on patients with sigmoid achalasia would be ideal for further study. Lastly, a prospective trial with robust reflux testing in patients who undergo short myotomy may help us better understand the effect of shortening the myotomy on reflux outcomes. In conclusion, with that, I'd like to again thank the ASGE and our audience for this opportunity. If you have questions after listening to this video or after reading our article, please do not hesitate to reach out to me or the senior author on this study, Dr. Moen Kashab, with any questions. Thanks again for your time.